A quorum being present, the Subcommittee on Early Childhood, Elementary, and Secondary Education and the Subcommittee on Higher Education and Workforce Development will come to order. Today, we will have opening statements from the chairman and the ranking members of our two subcommittees. And with that, I recognize myself for an opening statement. Good morning, and welcome to today's joint subcommittee hearing with our colleagues from the Subcommittee on Higher Education and Workforce Development. I'd like to thank our panel of witnesses and our members today for joining on this important discussion on opioid abuse and addiction that is taking a toll on the nation, as we see every night on our television sets, if not from other places. The opioid crisis is having a profound impact on families, jobs, communities, and the economy, and that is why we're here today. The issue of drug overdoses due to opioids is only getting worse, as death related to opioids have quadrupled since 1999, and we have some fast facts up on the screen detailing all this. In fact, in 2016 alone, there were approximately 64,000 fatal drug overdoses. This means that the opioid crisis is claiming the lives of 175 Americans per day. These figures are horrifying and sad, not only for the country's future, but for communities who are losing parents, husbands, wives, teachers, and yes, students. Additionally, the opioid epidemic knows no age, gender, educational, credential, or class distinction. This crisis is touching all of us. Some of the most unfortunate stories have to do with children whose lives have been forever changed by this public health emergency. Between 2000 and 2014, the number of babies born drug-dependent increased by 500%. In my home state of Indiana, a recent pilot program from the State Department of Health found that about 1 in 5 infants assessed at hospitals around the state tested positive for opioids. 20% of our babies in Indiana. More and more children are being placed into foster care or are cared for by another relative due to potential or parental drug abuse. According to a recent analysis, nearly a third of the children who entered foster care in the U.S. in 2015 alone did so at least partially because of parental drug abuse. It is one thing to read the statistics and accounts in the news about communities in the midst of an opioid crisis, but these accounts do not compare to the real voices we need to hear from in order to understand this crisis. I had the opportunity to host a school safety summit last week in my district. One of the two significant topics was the opioid crisis. I heard from Dustin Noonkester, one of the founders of Brady's Hope. Dustin lost his son to opioid overdose. This organization is a resource to members of the community on how to spot abuse, how to address opioid misuse, and how families can help one another treat opioid addiction. Now, Brady was a good student. He was off to a military career, and he had 2 weeks to go before boot camp when his life was claimed by this. And it happened over the course of one summer. Started meeting with kids that he hadn't before, and one thing led to another, and he was 2 weeks short of getting to boot camp, where his life would have been saved. The epidemic can no longer be ignored, and it is important that we hear from those who are on the ground and facing tragic truths of this opioid crisis every day. The witnesses we have gathered here today understand the opioid problem better than any of us here in Washington, perhaps, because they see it and they fight it in their communities nearly every hour of every day. So I'm pleased this committee can come together to understand this true public health emergency and its impact on communities across the United States. And with that, it's now my pleasure to yield to the ranking member of the Subcommittee on Early Childhood, Elementary, and Secondary Education, my friend Congressman Polis, for his opening remarks.
Thank you, Chairman Rokita, for holding this very important hearing. As we know, the opioid crisis cuts across state lines, across party lines. It affects each of us in our congressional districts and many of us in our neighborhoods and families. In my home state of Colorado, the rate of drug overdose deaths since 2000 has more than doubled. The impact of the opioid crisis needs to engender a strong bipartisan response from Congress, and I'm thankful that we're beginning to have an important discussion through our joint subcommittee this morning. Addressing the opioid crisis should be a top priority for United States Congress, for our states, for our local governments. Last year, Congress passed and President Obama signed a law with a new set of policies that helped restructure our prevention and treatment efforts to better respond to substance abuse problems. Unfortunately, it did not provide the funding necessary to effect change and end this crisis. We need to match our rhetoric with action and with real resources. That means understanding the role that many programs fill in crafting a holistic approach to the crisis, programs within the jurisdiction of this committee and programs within the jurisdiction of other committees. For example, early learning programs helping care for children who experience the trauma of having addicted parents. Public schools are on the front line in the delivery and coordination of services for students impacted by addiction. Congress should fully fund programs authorized under ESSA to ensure that teachers and school leaders are equipped to be ready and willing partners in addressing opioid addiction and opioid use disorder. We can't overstate the importance of access to health coverage in this discussion. Medicaid and the Affordable Care Act have been improved and expanded to provide health care coverage to many who lacked it. In my home state alone, 400,000 Coloradans have access to health insurance through the Medicaid expansion alone. Finally, as we address the opioid addiction crisis, we have to remember that many communities were suffering from substance abuse disorders long before this current crisis. While the level and number of deaths has increased, addiction has always been a problem in our communities, in both rural communities and urban and suburban communities in every congressional district. We need to think critically about alternative options to addressing this crisis. For some communities, such as veterans, as we see in Colorado, cannabis should be considered as a replacement therapy for chronic pain management. Research suggests that implementing medical cannabis programs can reduce pain management medications associated with mortality, like opioid prescription drugs. It also can improve pain management and significantly reduce healthcare costs. In fact, a recent Journal of American Medical Association study analyzed all 50 states and found that those with medical marijuana laws had 25% fewer fatal opioid overdoses than states that did not have those laws between 1999 and 2010. At this time, I ask unanimous consent to place this study in the record.
Without objection.
Recently, I was honored to present a Purple Heart to a veteran who lives in my district. This 29-year-old man put his life on the line for our country, and he told me he uses medical marijuana for all of his pain management and sleep issues, and he's been able to successfully take himself off of the prescription opioids that the VA prescribed. His girlfriend also bore witness to the fact that he's much better for it. And these are the kinds of stories and data that we need to look at in addressing the opioid crisis. It's encouraging that Congress is taking this time to discuss the issue, and it's important that this committee is staying involved in the federal response to the opioid epidemic. I know that members on both sides of the aisle will have thoughtful questions and ideas, both to address the under-resourcing of programs and to make sure that we can address this issue in a comprehensive manner. I want to thank our panelists for taking the time to testify today. I look forward to hearing from everybody, and I yield back the balance of my time.
I thank the gentleman. I will now yield to the chairman of the Subcommittee on Higher Education and the Workforce for his opening remarks.
Thank you, Chairman Rokita. I want to echo the chairman's appreciation for the witnesses here today. The opioid crisis is having a profound impact on my constituents as well, and I'm sure the stories we hear from the witnesses today will resonate with many of the stories I've heard in Kentucky. The opioid crisis is a public health emergency, and Congress must continue working to face the epidemic that has had an impact on all aspects of our society. Unfortunately, a problem as widespread as the opioid epidemic, which has already had an impact of 11.5 million Americans, has also taken a devastating toll on local economies and the national economy as a whole, and we're only beginning to see more clearly. As the opioid public health emergency continues to worsen, the economy will continue to suffer. Data from CDC analyzing opioid overdose deaths by age groups in 1999 and 2015 show that people most likely to die of an opioid overdose are between the ages of 25 and 39 years old. These are people who had entire lives, careers, and untold contributions to make to their communities and our country ahead of them. Numbers are important, but people with their own stories are at the heart of this crisis. To Americans who live in some of the areas hardest hit by the opioid crisis, including my home state of Kentucky, they are seeing their coworkers, bosses, friends, and family members suffer from this horrible affliction. The administration and Congress are coming together to identify community-based solutions to combat this crisis. But the day-to-day hard work fighting this outbreak is already being done on the ground by the people that face this issue every day. The witnesses we have gathered here today have seen the impact of opioid crisis is having on their communities every day, and it's important we hear the stories of how it specifically impacted them as individuals, as well as their friends, families, and coworkers. When it comes to finding solutions for the workforce development needs and creating more good-paying jobs, we look to state and local entities who are leading by example, and the opioid crisis is no different. Our witnesses before us have learned a lot in their communities about how to spot opioid abuse and implement successful forms of treatment. It is important we hear about these experiences in order to inform the congressional response to this crisis. At this committee, we talk a lot about how we are addressing the shortage of skilled workers across the country and how we want to empower people to build the lives they want for themselves. For many workers ensnared in this epidemic, it is critical that they receive the treatment they need to help them return to the workforce and to find a good job once they are drug-free. We also have to acknowledge that the opioid crisis is resulting in too many lives ending far too soon. We have to look at ways to stop it. I'd like to welcome Tim Robinson here today from my home state of Kentucky. I know that Tim and I were discussing earlier, Louisa, where he's from, is probably closer to this Capitol building than it is to my hometown of Bowling Green, but it just shows how broad and wide and diverse Kentucky is, and the problem is pervasive through all economic groups, all people, and it is something that we are struggling with. I know that the dean of the Kentucky delegation, Hal Rogers, has been a strong supporter of what you do in Louisa and Martin County and all through Appalachia and also across the Commonwealth. So I certainly appreciate you being here today, and your testimony in a few minutes. I appreciate the witnesses for appearing, and I look forward to hearing your testimony, and I yield back.
Thank you, Chairman Guthrie. I now yield to the ranking member of the Subcommittee on Higher Education and the Workforce, Congresswoman Davis, for her opening remarks.
Thank you, Mr. Chair. As my colleagues have said, and I want to point out how much in sync I think that we are on many of these issues, the opioid crisis has greatly impacted our communities. In 2015, more than 33,000 Americans died of an opioid overdose, and more than 2 million individuals had an opioid use disorder. In California, more people die from drug overdose each year than from auto accidents. That's why it's so important to continue to invest in the federal programs to promote addiction recovery and treatment. Across the country and in California, Medicaid has been vital to addressing the opioid epidemic. Adults with Medicaid coverage are about 3 times more likely to have received treatment as inpatients and almost twice as likely to have received outpatient treatment than privately insured adults. As Ranking Member Polis has noted, in our efforts to combat this epidemic, it's vital that we invest in the systems and the programs that support healthy families and communities. And this means a strong workforce, and I'm pleased that my colleague has also echoed that interest. As we've seen with past drug epidemics that have rocked our communities, the opioid epidemic has a strong link to jobs. According to recent research, an estimated 25% of the drop in women's workforce participation between 1999 and 2015 can be attributed to the increase in opioid prescriptions. And for men, that number is about 20%. And we know that when adults, particularly women, aren't working, it has significant impacts on the economic security of their families and communities. For example, job loss for a parent can mean lower wages and unemployment for their children later in life. It's particularly important to note the relationship between opioid abuse and unemployment. This means that individuals may fall out of a job force due to their dependence on opioids, or it may be that they become addicted after job loss. We must help people remain employed and break down barriers for individuals struggling with opioid abuse problems as they seek to reenter the workforce. And this means rethinking employer drug testing policies and using a more thoughtful approach for those in the criminal justice system. We must also leverage our workforce development systems to ensure that our workers, especially those in communities impacted by trade and technology, have access to the skills development that they need. Integrating job training into treatment efforts is also key. Linking these services can be crucial for helping people reenter the workforce and improve the probability of long-term recovery efforts. And now we know that the Trump administration has declared a nationwide public health emergency to address the opioid crisis. And as part of this declaration, the administration has directed the Department of Labor to use dislocated worker grants to, and I quote, help workers who have been displaced from the workforce because of the opioid crisis, subject to available funding. Unfortunately, we will not be hearing from anyone from the administration today to get a better understanding of their plans. And that perspective would have been very helpful, I believe, for understanding why they would encourage the use of these grants, but also at the same time call for a 40% cut to their funding. As I'm sure many of my colleagues today will underscore, substance abuse and its impacts on its impacts on communities is nothing new. And if there's anything that we've learned from past failures in addressing this problem, it is that resources do matter. In addition to investing in treatment and recovery programs at the back end, we must also address the poverty, the violence, poor health care, and inadequate education that can be contributing factors to unhealthy communities. I look forward to hearing about what investments are needed to address a crisis of this magnitude without robbing other vital programs, such as family support services and job training that support families and communities. I want to thank the witnesses for being here today, and I certainly want to congratulate Dr. Leana Wen on her newest addition to her family. Look forward to your testimony and hearing more about how we can address and help communities impacted by the opioid abuse its crisis. Thank you very much for being here.
And the gentlelady yields back. Pursuant to Committee Rule 7C, all members of the subcommittees will be permitted to submit written statements to be included in the permanent hearing record. And without objection, the hearing record will remain open for 14 days to allow statements, questions for the record, and other extraneous material referenced during the hearing to be submitted for the official record. We'll now turn to the introduction of our distinguished panel of witnesses, and I yield to Chairman Guthrie to introduce our first witness.
First, I'd like to introduce Mr. Tim Robinson, is the founder and CEO of Addiction Recovery, and has 13 organizations that are networked through Eastern and Central Kentucky, and I talked about him in my previous remarks. So welcome, and look forward to your testimony. I'll yield back to the chairman.
Thank the gentleman. I yield to Ranking Member Polis for the introduction of the second witness.
Thank you. I'm honored to introduce Toni Miner. Ms. Miner is a fellow Coloradan from Jefferson County, Colorado, which I have the honor of representing much of. She's currently working as a family support partner with the Jefferson County Child and Youth Leadership Commission. Prior to this position, Toni Miner served as a family advocate with the Child and Youth Leadership Commission. She also worked as a parent partner for 5 years. In addition to mentoring families, she also provides training to caseworkers on the ground. Court-appointed special advocate volunteers she helps train as well. Ms. Miner has been active in the child welfare system team decision-making meetings and serves on the Domestic Violence and Child Protection Services Coordinating Council. Welcome to our committee.
Thank you. I thank the gentleman. I'll now resume introducing our witnesses. Dr. Leana Wen is the Commissioner of Health for the City of Baltimore, Maryland, and Dr. David Cox is the Superintendent of Schools in Allegheny County, Maryland. Welcome to all the witnesses. I'll now ask the witnesses to raise your right hand and repeat. Do you solemnly swear or affirm that the testimony you're about to give will be the truth, the whole truth, and nothing but the truth? And let the record reflect that all witnesses answered in the affirmative. Before I recognize each of you to provide your testimony, let me briefly explain our lighting system, and it's a reminder for us up here as much as it is for you. You will each have 5 minutes to present your testimony, and when you begin, the light in front of you will be turned green. When 1 minute is left, it'll be yellow, and when your time has expired, the light will turn red. At that point, I will ask you to wrap up your remarks. After everyone has testified, members up here will each have 5 minutes to ask questions of each of you. And so with that, let me recognize Mr. Robinson for 5 minutes. Thank you, sir.
Good morning. My name is Tim Robinson. I'm the founder and CEO of Addiction Recovery Care. As already mentioned, there were more deaths due to overdoses than car accidents last year, making addiction a public health crisis. The addiction epidemic is not just costing us thousands of lives, it is also threatening our economic security as employers struggle to find and retain employees who can pass a drug screen. In September, our Kentucky Chamber of Commerce CEO wrote an op editorial that called addiction the #1 economic concern in our state. Everyone is looking for a silver bullet to the addiction crisis. and there is no single intervention that alone is a silver bullet. Addiction recovery requires a whole person approach, which starts with identifying those in addiction, intervening with treatment, investing in their economic future through education and workforce development, and inspiring them to join the effort to do for others what was done for me. Help another person discover their destiny and walk out their recovery. I'm thankful for the opportunity to speak to you because recovery is personal to me. I started drinking in my first year of law school at the University of Kentucky to cope with my mom passing away from terminal lung cancer during finals. For the next 8 years, I almost drank myself to death. 10 years ago, while I was a prosecuting attorney in Lawrence County, Kentucky, a court bailiff who was a recovering alcoholic and a pastor led me to a spiritual awakening at my desk. He became my sponsor, but he also became my pastor, and he carried me for a while, and he walked with me and poured his recovery and his faith into me. Addiction recovery is personal to me because I am a survivor. 2 years later, I resigned as prosecutor, gave my law practice to my law partner, and in 2010 opened Karen's Place, a recovery center for women in eastern Kentucky. Since opening our first center, we've realized that addiction is a disease that devastates all aspects of a person's life, and that a holistic approach is crucial for long-term recovery. Addiction impacts someone's mind, body, spirit, and their purpose. And we've been determined to treat addiction medically, clinically, spiritually, and vocationally. And though our centers are led by an addictionologist and are nationally accredited, Alcoholics Anonymous has taught us that a spiritual awakening is the foundation of lasting recovery. In that tradition, we've developed a spirituality program that inspires hope and offers those coming out of an addiction an opportunity to understand that God is the source to find hope, forgiveness, and redemption. Much like hospice care centers and Catholic healthcare systems, we employ chaplains and pastoral counselors who work alongside our clinical staff. And though we consider the faith-based aspect of our centers to be the heart of our success, our spirituality program does not replace medical and evidence-based clinical practices. It's an addition to them and makes our care more comprehensive. Treating the whole person has led to great success. Our clients stay in treatment for 60 to 70 days compared to a national average of 25 to 30 days. This objective measure shows our residential centers to be twice as effective as the national average. Readmission is another objective measure. Those in addiction who relapse most often return to the same center 40% of the time. Less than 10% of our clients readmit. As we build our treatment network, we've had a great need for addiction treatment workers, and we've created an internship program and issued a challenge. Clients who intern with us until their 1-year clean mark would be guaranteed a job. Today, 70 of Addiction Recovery Care's 200 employees are graduates of our program. We formalized our internship program, becoming a state-certified peer support specialist training program. A peer support specialist is a recovering addict who has at least 1 year of sobriety. After a 40-hour class, they become a Medicaid billable behavioral health practitioner and can provide those in addiction with peer support. SOAR, an economic initiative in Kentucky's 5th Congressional District, connected us with the Workforce Board, Eastern Kentucky Concentrated Employment Program, and their Executive Director, Jeff Whitehead. With the Workforce Board providing funding, we partnered with Sullivan University to transform our internship program into a workforce development opportunity. Our program graduates become state certified and earn a college certificate. There's also soft skills development and professionalism and workplace ethics. They receive other skills such as CPR, first aid, and using a medical record, electronic medical record. In 2016, we started our first class, and 16 peer support specialists graduated in May of 2017. Out of the 16 graduates, 14 of them are at least 8 months clean and sober today, working full-time, paying taxes, and transitioning off of public assistance. These 14 people now have great purpose and meaningful careers. We now have more than 50 others in the academy today. Prior to the academy, 40% of our clients moved to our transitional program. After starting the academy now, 70% of our clients now choose to continue treatment.
Thank you, Mr. Robertson. I appreciate that very much. Ms. Minor, you're recognized for 5 minutes.
Good morning. I wish to thank the Committee on Education and Workforce for providing me with this opportunity to share my perspectives with you today. My name is Toni Miner, and I'm a birth mother of 3 children, Mercedes, Jonelle, and Spencer, and the legal guardian for my 2 grandchildren, Angel and Taven, and we live in Jefferson County, Colorado. My story is that of a mother who was heavily ruled by her addiction to methamphetamine. My meth use became daily in 1996 and continued until 2002. Unfortunately, my 2 beautiful daughters had to live through my active meth addiction. I didn't think my meth use really had an effect on my girls, as I was providing a roof over their head, food on the table, and clothes on their backs. But what my daughters wanted and needed more than anything in this world was a clean and protective parent. Now, during this time of my meth use, I received many criminal charges that were due to my use. I had burned all my bridges and had no support, and I really didn't see any way out of my addiction. Then I found out that I was pregnant. I had no idea what I was going to do or how to get clean, but knew that I had to. I had hit my rock bottom. Because I was finally ready to get clean, I was able to take the first steps and stop my meth use, with the support of my amazing caseworker and probation officer who did not judge me, but encouraged me. My daughters returned to my care the day that I was released with the understanding that I would comply with the probation requirements and complete intensive outpatient treatment. Today, almost 16 years later, I am still clean and actively involved in a recovery program. I have rebuilt relationships with family, made many new friends, and have many supports in my life. Unfortunately, my poor choices did take a toll on my 2 daughters, who eventually became addicted to drugs. Today, as a kinship care provider, I can make sure that my grandchildren are safe from any future harm. Besides working to ensure that my own family is strong and safe, I also work to help families who are impacted by child welfare and struggling with addiction, working as a family support partner in Jefferson County, Colorado, and also working in our problem-solving court, which is our family drug court in Jefferson County. I am able to educate and empower struggling families with the skills and knowledge to navigate multiple systems and advocate for their own supports and connections within the community. I also work with families through facilitating a Circle of Parents in Recovery group, which are specialized parent support groups designed to build protective factors in families, addressing substance abuse and the impact of trauma. Through my personal experience and my work with families, I am able to provide you with recommendations that I believe will help strengthen families, especially during the opioid crisis. 1, collaboration across agencies is a must to ensure that children and families are getting the right services they need efficiently. Families interact with multiple systems with their own requirements, processes, and it is essential that these systems work together to ensure families get the help they need. Law enforcement, child welfare, schools, mental health, housing, courts, hospitals, employers, substance abuse programs, and methadone clinics should all be part of the process to help strengthen families struggling with addiction. 2, focus on the whole family. Addiction is a family disease, and if the whole family is not treated and provided the right supports, history will continue to repeat itself, as it did within my own family. Families at risk respond best to supportive and strengths-based approaches. Both my child welfare caseworker and probation officer believed that I could change and become the strong, resilient, and healthy parent that I am today. 3, educate our communities and families regarding substance abuse. Public service announcements must talk about link between substance abuse and mental health and include available resources for treatment. Children must be educated, especially prevention education of the children of adult addicts. 4, partner with parents to work with other families before, during, or after involvement with the child welfare and court systems. We need to partner with parents like me who have learned from their own experiences and can help other families navigate complex systems and access services. Many states and local jurisdictions are implementing parent-partner programs and finding this can be a very useful strategy to effectively engage parents in their child welfare cases and treatment. These voices are also important as they educate policymakers, administrators, frontline workers, and others interacting with families. If we implement these recommendations and invest in families, the sky's the limit in what we can achieve together. Thank you for your time.
Thank you, Ms. Miner. Dr. Wen, you're recognized for 5 minutes.
Chairman Rokita and Guthrie, ranking members Polis and Davis, thank you for calling this hearing. I'm here as an emergency physician and the health commissioner of Baltimore, where overdose claims the lives of 2 residents a day, and where addiction affects every aspect from the workforce to our youngest children. Baltimore has a 3-pillar approach. First, we focus on saving lives by making the opioid antidote, naloxone or Narcan, available to everyone. Not only have we equipped paramedics and the police, I issued a blanket prescription to all 620,000 of our residents. Since 2015, everyday individuals have saved the lives of 1,500 people. But we have a problem. Our city is out of funds to purchase naloxone, forcing us to ration and make decisions every day about who can receive the antidote. At a time of a public health crisis, it is unconscionable that we are being limited in our ability to save lives. Our second pillar is to increase on-demand addiction treatment. The science is clear. Addiction is a disease. Treatment exists and recovery is possible. Nationwide, only 11% of patients with addiction get treatment. Imagine if only 1 in 10 people with cancer can get chemotherapy. Yet my patients come to the ER asking for help, and I tell them they must wait weeks or months. I've had patients overdose and die while they're waiting because our system failed them. In Baltimore, we started a 24/7 phone hotline that includes immediate access to a social worker or addiction specialist. We receive 1,000 calls a week. We're starting a 24/7 ER for addiction and mental health. We believe that treating addiction as a crime is unscientific, inhumane, and ineffective. That's why we have programs like LEAD, Law Enforcement Assisted Diversion, where individuals caught with small amounts of drugs will be offered treatment instead of incarceration. Law enforcement to stop the trafficking of drugs is important, as is more judicious prescribing by doctors. However, reducing the supply of drugs will not work unless there's equal attention to curbing demand through providing treatment. That means the federal government should do everything possible to expand insurance coverage. 1 in 3 patients with addiction depend on Medicaid. If Medicaid were gutted and they were to lose coverage, many more would overdose and die. Other patients on private insurance could find themselves without access to treatment if addiction is no longer required to be part of their health plan. Essential health benefits are called essential for a reason, and all insurance plans should cover preventive care and evidence-based addiction services, including the gold standard, which is medication-assisted treatment. Block grants should not replace insurance coverage because no disease can be treated through grants alone. We on the front lines know what works. We have done a lot with very little, but this is a national emergency. We desperately need new resources, not repurposed funding that will divert from other critical priorities. These funds should be given directly to communities of greatest need. Cities and counties have been fighting the epidemic for years, and we shouldn't have to jump through additional hoops like competing for grants and having funding pass from the states to cities that will cost time and more lives. Our third approach is to reduce stigma and prevent addiction. We have trained all of our nurses in our 180 public schools to save lives with naloxone, and we now have addiction and mental health services in 120 of our schools. Opioid addiction affects those even younger. More than half of children who die in Baltimore have a parent or caregiver with addiction and mental health concerns. Home visiting for pregnant women helps to identify families in need of treatment and support. This is a key component of our citywide strategy, Be More for Healthy Babies, which has successfully reduced infant mortality by nearly 40% in 7 years. The opioid crisis requires proven public health approaches spanning the entire life course. In closing, we know what works. We need support from the federal government with 3 actions. First, protecting and expanding insurance coverage to get to on-demand treatment for the disease of addiction. Second, allocating additional funding to areas hardest hit by the opioid epidemic directly to local jurisdictions. And third, supporting early interventions for women, children, and families. By the time this hearing is over, at least 10 more people will have died from overdose. I urge Congress to commit the additional resources needed to save lives and reclaim our communities. I thank you for calling this hearing.
Thank you, Doctor. Dr. Cox, you're recognized for 5 minutes.
Good morning, Chairman Rokita, Guthrie, and Ranking Members Polis and Davis. Thank you for the invitation to be here today to share the very deep impact of a real struggle affecting our district students and our community. As stated, I am the superintendent of schools in Allegheny County, which is located in western Maryland, where it's been my honor to serve as its superintendent since 2009. Just a few quick facts about Allegheny County. The median income is just over $40,000. The population there is about 72,000. Our current student enrollment, 8,700. Our free and reduced meal population in the school system is 55% countywide. Our special education population is 16%. And according to our sheriff, this year to date, there have been 27 overdose deaths in our county. Last year, there were 59. Today, I want to share the impact of opioid abuse that affect my students each day and the dramatic change that I've witnessed in just the past 5 years, and with each successive year getting progressively worse. One of the first was a decline in our attendance and parental involvement in the child's schools. We work very hard as a priority of our local board to provide every child in our county with a high-quality preschool experience in our district and to identify the learning needs of children as early as possible. In doing so, we've experienced a sharp increase in the number of children who require special services due to the opioid issues. 18% of all newborns in Allegheny County are born drug-affected, and this statistic does not include those children who may have prolonged prenatal exposure to alcohol. Last year, we experienced multiple occasions where parents overdosed and died in their homes while their young children were present. On 2 different occasions during the preschool home visits, our staff encountered young children who answered the door, and each of those times when asked where their mother is, the child said she's asleep. And when further investigated, one of the mothers was deceased, another was brought back through the use of Narcan. In one particularly sad and impactful occasion last school year, we had a kindergarten student who came to school on a Monday morning after staying with her father over the weekend. When she got to school, she was sick and she had a fever. The school nurse tried to call the mother since the custody schedule indicated that the mother was the Monday caregiver. When the mother did not answer the phone, the school's secondary emergency contact was her grandfather, who was contacted, and he picked her up for medical attention. No one could have imagined that this child's mother and the mother's boyfriend had overdosed in the mother's home, at which time the boyfriend's also 5-year-old son was in the home and not in school. When the little boy ran out of food in his home, he went to neighbors' houses and knocked on doors for food, which led to the discovery then that the little girl's mother and the boyfriend were dead from an overdose of fentanyl. It was estimated by our authorities that the mother and boyfriend had been dead for 2 days. My elementary principals have shared with me this year that they're experiencing more and more incidents of children who have severe behavioral issues when they enter school. Some of our preschool age and kindergarten students require full-time adult support just to manage their behavioral issues as they work with individual behavioral support plans, and often there's limited parental support. The good news in all this is that for many of our children who've been so impacted, their public school is the place that they're the most loved, the best cared for, and where they receive the best nutrition, they're the warmest, and where they're shown the most kindness. And so for this, I'm grateful to our caring teachers and schools and staff members where they can grow and learn. Allegheny County Public Schools has revised its health curriculum to include specific information for students regarding substance abuse at all grade levels. We've particularly focused on the high school level on prevention of opioids, where we've enlisted the help of 2 recovering opioid addicts who give presentations to students in high school health classes. All schools are now stocked with naloxone, and staff members know how to administer the opioid antidote to persons who are believed to have overdosed. While I do appreciate that President Trump has recently recognized the opioids as a national crisis, it is my hope and plea that our federal government will allow flexibility and use of federal funds to allow school districts to utilize resources to help with our efforts to combat this crisis and to tend to the many unmet needs of our children. There is a good opportunity that Title IV funds in the new ESSA regulations could provide some of those flexibilities. I have great difficulty in finding the words to describe the magnitude of the unmet mental health issues and health issues of my students and families. Many are self-medicating their depression and anxiety, and many suffer from generational addiction. Others have become addicted to prescription pain medicine and have migrated to opioid addictions. Others, our children, are left with deep emotional scars when they lose the parents due to overdoses, and there aren't enough resources to provide all the needs for counseling, therapy, and treatment. Keeping options open for children's health insurance programs is a critical need. I want to express my sincere appreciation and opportunity to be here today, and if there's anything that I can do, or AASA, we would certainly be glad to have you contact us.
Thank you, Dr. Cox. Appreciate all the witnesses' testimony. I'd like to recognize the chairwoman of the full committee, Dr. Fox, for 5 minutes.
Thank you, Mr. Chairman, and thank you for convening this hearing. It is a very, very painful topic to be talking about, but is one that I know we need to discuss. Mr. Robinson, you talked in your testimony, you talked about workforce preparedness and helping to educate people. How does preparing and educating individuals to re-enter the workforce increase their motivation for treatment?
Vocational education as a part of the continuum of care for addiction treatment drives greater levels of success for really 3 reasons. One, when someone enters treatment and knows there's a second chance career path, it inspires hope and increases treatment motivation. Number 2, the 12th step of AA informs us that sharing our recovery is one of the foundations of long-term sobriety. So this concept suggests that finding purpose and in helping others strengthens your own recovery. And then finally, and I think most importantly, experiencing the dignity of work gives recovering addicts who have re-entered the workforce a positive self-image, confidence, and helps them to establish career goals and a plan for their future. A great example of this is Vanessa Keaton, who was an IV heroin needle user who entered one of our residential treatment centers and completed our internship program. She later became a treatment center director while earning a college degree and purchasing her first home. And recently, she resigned as our HR director and now started a business that is supporting her family.
Thank you very much, and thank you particularly for mentioning the dignity of work. I don't think we do that often enough in our conversations. Ms. Miner, you discuss how families need to be part of their own solution. Can you elaborate on what this means? And my assumption is it's different for different families, but you might want to give examples of that.
Absolutely. Families are different. They're unique in their own ways. Really, in my position in Colorado, I sit down with the families and discuss with them what it looked like for them when things were going well for them, before their addiction had taken its toll, what their children looked like, what kind of supports they had in their family, because all too often we find that when someone is in active addiction, that they have really severed their ties with all of their good supports in their life, and they really believe that this is severed for life. I share my story with them and tell them about how bad I had hurt my own mother through my addiction, and she's now my best friend again and my biggest support. And really, we have got to get these families to believe that they have the power within themselves to do it.
Thank you very much. Dr. Cox, I represent Allegheny County in North Carolina, but we spell it just slightly differently. We put an H in it there. Our county's not as large as yours, and I don't think it has quite the same problems. But I love representing Allegheny County in North Carolina. You discussed the need for flexibility for the use of federal funds to allow school districts utilize available resources to help meet the needs of the students. How would additional ESSA Title IV fund flexibility help you as you respond to this problem?
Well, let me give you a very specific example. And I go back to a meeting I was in yesterday with my elementary principals. It was our regularly scheduled time, and we talked about some of these issues and the presentation of kids with lots of needs. In our district, we have one behavioral specialist that serves the needs for all of my 13 elementary schools. While I'm grateful that we have the Title IV funds, it comes, you basically have to write your plan to fulfill 3 different areas. And in our county, we get $70,000. And it would be helpful if I could pool all of that money to be able to hire another behavioral specialist to help with my elementary principals and the counselors and nurses in the schools to design plans to deal with the behavioral issues. I mean, that's one example, but I think, in all of our public schools in Maryland across the country, having greater flexibility within the federal entitlement programs to meet the specific needs in each of our jurisdictions would be very helpful to all of us.
Thank you, and thank you. Thanks to the panelists again, and thank you, Mr. Chairman, for indulging me. I yield back.
I thank the chair lady. I recognize Ranking Member Scott for 5 minutes.
Thank you, Mr. Chairman. Mr. Chairman, it seems to be a consensus that we should treat the opioid addiction as through a public health strategy rather than a criminal justice strategy, which means primary prevention before people get in trouble and then responding afterwards. Dr. Wen, you mentioned in your final closing statement a need to support early intervention for women, infants, and children. What does that mean, and what can be achieved?
Thank you for that question. We need to have early intervention and detection. That would include things like home visiting services, which have been found to have profound long-term effects on improving children's health and also the health and well-being of their families, too. We know that there is a cycle that exists, this cycle of poverty, trauma, addiction, that addiction often begets addiction. And we need to do everything we can to break that cycle, to have early intervention where possible, to have prevention services, but also critically, when people are seeking treatment, we need to be there for them. We should not have to tell them to wait weeks or months, but we should make every interaction the opportunity for intervention.
Well, if you're going to have a public health response as a cost after they get addicted to paying for the services, can you repeat what you said about the effect of cuts in Medicaid and removal of behavioral health coverage as an essential benefit in health policies?
Absolutely. In Maryland alone, there are 250,000 people who gained insurance because of expanded Medicaid. All these individuals could stand to be without access to treatment if Medicaid were cut. Essential health benefits, too. 1 out of every 3 individuals who now are newly insured through ACA plans might not have gotten coverage before because essential health benefits do not include addiction services. For all these individuals, there is no margin of error. So an individual who is in treatment now, if they don't have treatment tomorrow, their only option may be to overdose and die. And at a time of a public health epidemic, the last thing that we can afford to do is to deprive people of the coverage they have instead of providing access to treatment for the 1 in 10, for the more than 1 in 10 who cannot access it now.
You made a comment about dealing with the supply. Can you say why investments in cutting supply are inherently unsuccessful?
Well, currently, substance abuse already costs society $600 billion annually in medical costs and incarceration costs, so we need to invest much earlier. And cutting supply alone is not going to work unless we also address demand, because currently we have millions of people who have the disease of addiction. If we're not able to get them treatment, that demand is going to continue to fuel supply. And that's why a public health approach combined with a law enforcement approach are what we need. That's the humane thing to do, the ethical thing to do, and it saves society money.
Thank you. Dr. Cox, you indicated that superintendents need flexibility with their funding. Isn't it true that superintendents have also been asking for significant increases in funding, particularly Title IIA funding and other funding that can help address this, not just flexibility, but more resources?
Sorry. We have a lot of needs, and certainly additional funding would be helpful. One of the greatest needs is that for treatment, that we have children whose mental health needs are not being attended to because there aren't enough resources to do that.
And so you need more resources, not just flexibility.
Yes.
Thank you. And Mr. Chair, I'll yield back.
I thank the ranking member. I recognize myself for 5 minutes. I thank the witnesses again. Mr. Robinson, you mentioned Alcoholics Anonymous, and pardon my ignorance, does it receive federal funding?
No, it doesn't.
So that allows you to explore the spiritual element of the recovery process?
Yeah, absolutely. And again, in our treatment centers, we still have an addictionologist leading our medical programs. We're nationally accredited by CARF, so we are recognized as a Center for Clinical Excellence. But we've added two things to our programs that maybe not all programs have, and one is a spirituality program, which is very, very important, especially when you start looking at pastoral care and chaplains, and that's very consistent with other faith-based health systems that we have across the country. And then finally, as I said in my comments, we've added vocational workforce development as a key part. And so you really have to treat the whole person, and spirituality is a piece of that.
And funding source aside, and regardless of it, you recommend spirituality and vocational for every program?
Absolutely. I think we should be investing in programs that are holistic, that are treating the whole person, and addiction devastates every aspect of someone's life.
Thank you, Mr. Robinson. And then you mentioned Medicaid-eligible health care providers. Can you unpack that a little bit?
Yeah, I mentioned the peer support specialist in our state is a Medicaid billable professional, which is incredible public policy because it creates employment for people recovering from addiction. And it puts them to work in a field that's the best thing for them to do, which is to share the recovery with other people. And so in our state, for some billing codes, a peer support specialist who's someone who's been clean and sober for a year, that's either got a high school diploma or GED, that goes through a 40-hour course, they become a behavioral health practitioner, and organizations like ours hire those individuals to lead group, to do individuals, to go to needle exchanges, to go to ERs.
What's the cost to get them trained or educated, so that they're Medicaid eligible, Medicaid billing eligible?
So
roughly,
it's a 40-hour course, and our academy has added lots of other skills. Our Workforce Development Board provides us approximately about $10,000 for each one that we train. But we're training super peer support specialists that are certified in CPR, first aid, and one of the other things about peer support specialists is it prepares them when they start getting this medical training. They can go into other careers other than peer support and enter the nursing field or other healthcare professions like medical assistants.
Thank you, Mr. Robinson. Let me skip over to Dr. Cox here. You mentioned, I believe, if not your oral testimony, your written testimony, community task forces.
Yes.
Can you unpack that a little bit?
Sure. We have several.
How do you organize them? Who's involved? What's the cost associated with it? What's your funding source if there is a cost to the county?
We have several, actually. The Western Maryland Health System sponsors one, they're called, actually, the Summit, and they're the recipient of some state grant funding.
Summit?
The Summit, okay. Right? I'm a member of the Greater Cumberland Committee, Education Workforce. They also had an event, a forum, and then we have staff members who participate in various committees with the health department. We have a lot of efforts underway. Our sheriff, as a matter of fact, this evening will kick off another series of town hall meetings all over the county. So we've done a really good effort of educating the population about what addiction is.
What's the effect so far? Can you tell?
Well, I think we're a lot better educated as a community about the aspects. I mean, for example, just educating people who have no experience with addiction that people use to feel normal. That's one of the hardest things, I think, for people to understand, is that a person doesn't use necessarily to get high, but just to feel normal, so that they can carry on and function. So that's one of the things that that we've.
Thank you, Dr. Cox. Coming back to Ms. Miner now, you indicated in your testimony, and thank you for sharing your tragic story as well. I appreciate the courage that must take. You mentioned that you thought you weren't affecting your kids. Perhaps I didn't even know. And then obviously you said you now have children that are or were drug addicts. So they did see your behavior. What do you think the cause is? Is it more than just observation? Or what's your instinct as a mother there?
They did see. They saw that I wasn't present. They saw that when they needed me to wake up in the morning to take them to school, that I couldn't do it. They saw that when they were clinging on my leg, wanting mommy time, that I could not be present.
Why does that make them become a drug addict in your mind?
You know, I really believe, and after talking to both of my daughters, that because they witnessed so much tragedy in their life and because there was so much trauma that was never dealt with them, When I first got clean, everyone swooped around me because I was pregnant with my son, but nobody helped my daughters who had suffered significant trauma. And trauma is a leading cause to substance abuse.
Thank you. And at the risk of breaking my own rules, I need to stop. I apologize. Thank you very much for your responses. I now recognize the ranking member of the K-12 subcommittee, Mr. Polis, for 5 minutes.
Mr. Robinson, can you confirm if your centers accept Medicaid and receive Medicaid reimbursement for services?
We do.
Okay, I just want to be clear to point that out as a federal funding stream. Ms. Minor, you know, I think the power of your personal narrative is very strong. Do you have any suggestions about what we can do either officially as a committee or unofficially as individuals to encourage more people like yourself to be open and share their own stories and narratives and help educate others?
I really believe that people like myself can help to build the power of the people in recovery up to want to come and talk. It's a very frightening thing to go out and share your story because you never know the reaction that you're going to get from people. We are our own worst critics, and we tend to think that everybody that we go and talk to is just going to look down on us. It's really about educating us and really helping us to get our voices out there, and for you to really want to listen, and for us to know that you want to hear what we have to say.
And, you know, I've also appreciated the movement that many families who have lost children or family members to the opioid epidemic have been more forthcoming in their obituaries to mention the true cause rather than sweep it under the rug. The more visibility and awareness, I think the more empowered we are to counter this deadly epidemic. Dr. Cox, I want to thank you for being here today and sharing some data about the opioid crisis. In your testimony, you talked about the funding struggles that your district is facing. In Colorado, when I meet with superintendents and school board members, often funding is one of the first issues they bring up. Still, school districts are being asked to do more with less. We've never met through this body our full commitment to special education funding. Most recently, there's significant scalebacks in funding for ESSA. For instance, eliminating Title II has been proposed and cutbacks in Title IV, Part A. Can you share the importance of fully funding federal education programs, specifically Title IV, and how this could benefit Allegheny County public schools in your efforts to support students and families impacted by the opioid epidemic? Sure.
You're correct. I mean, we have so many needs, and this opioid crisis has only contributed to that. And we're funded by a combination, and every state's a little bit different, but we have, most of our funds come from the state of Maryland. Second is going to be our local county government, and then the third pool is the federal funds. So we use a combination of all those funding sources to meet the needs, and as you mentioned, with IDEA not being fully funded, it really imposes some hardships, and this issue impacts the IDEA needs that children have, so it's only going to create more need for children. So, you know, whether it's additional funding for IDEA or Title IV flexibilities or additional Title IV funds, we just need more resources to deal with the issues.
And Dr. Wen, I want to thank you for being here this morning. I'm fortunate to represent a district with several research universities, University of Colorado at Boulder and Colorado State University, both of which are leading research universities doing great work to help better understand the opioid epidemic. In a recent study from CU in partnership with the VA in Colorado, they found that patients almost universally cited emotional support from family members and healthcare providers as essential to recovery. Can you speak to the emotional support for family members and healthcare providers, and specifically what Baltimore is doing to help provide emotional support services for patients?
It's critical to remember that when people are recovering from the disease of addiction, they need not only the medication-assisted treatment, which is also the gold standard, they also need psychosocial counseling and wraparound services and social services. And also that people who are addicted to opioids are not only treating physical pain, they're potentially treating some other type of pain as well that might include emotional pain and trauma. And so in Baltimore, we provide services for healthcare workers. We provide services also to assist with our most vulnerable, including our children in our schools.
And are those models, do you think they can be expanded or scaled, including in rural areas?
Absolutely. We have many evidence-based pilots and evidence-based programs in Baltimore. We know what works. We just need the resources to scale them up in our jurisdiction and across the country.
And I'll finally go back to Ms. Miner. Can you share a little bit about your personal experience as an advocate working across different systems and different jurisdictions that are all trying to work on this issue and how you've been able to try to bring people together through your own personal narrative and advocacy?
Absolutely. We are still very siloed, I'm finding out, across the country. But I am finding more and more, at least in Colorado, that people are wanting to work together. They're wanting to talk so that we can help eliminate the trauma to the family from the family having to tell their story over and over again. Because every time they have to repeat it, it's more traumatizing to them and to their children. And with me working so closely with the executives that we have in Jefferson County, it makes it that much easier for me to help them partner with each other and with the families. And they really want to listen to what the families have to say.
Thank you, and I yield back.
Gentleman's time's expired. Gentleman yields back. Chairman from Kentucky is recognized for 5 minutes.
Thank you very much. It's great to be here. And I just want to say this is something that's not going to be solved solely in Washington. It's certainly, you guys are on the front lines at the local level. I just want to point out for the witness testimony earlier joined us was Kim Moser from Northern Kentucky, which is not just the north part of our state. Northern Kentucky is how we define our Cincinnati suburbs. So if you live in Northern Kentucky, you're closer to a Reds game than if you live in North Cincinnati. And though the heroin opioids has been statewide, we call the I-74 corridor in Appalachia, where you are, has been really the brunt of it and all the work moving forward. And there's so many issues and there's so many committees here looking at this crisis together, but on the higher ed committee that I chair, we're really looking at how the opioid crisis is affecting the workforce. So I did my 21 town halls in August. Everywhere I went, most was talking about health care, but there was not one that people weren't talking about the heroin problem and opioid. They say heroin back home, but we're talking opioids in general. And so it's everybody is focused on it and wants to move forward. But every employer that I would talk to who were looking at, I think every employer I talked to in Kentucky, you probably find some rural areas, probably in your area that's not, but are looking for people to hire. And the biggest problem they're saying is passing the drug test. A lot of people who show up to work. So there's a lot of issues that we just can't look at the criminal justice problem. We got to look at holistically. I don't want to dismiss that part of it, but I've changed my attitude on that too, is that we've got to look at people are in trouble because they're addicts, not addicts the other way around. And so, but the big thing is, you said, I think you hit it, the dignity to get them to work. And I know your program does that. And so what are you hearing from local businesses? And I know that you tailor some of your programs from what local businesses have told you they need to get certificate programs. Could you address that, Mr. Robbins? I'm sorry, I'm talking to you.
Our first training program was to provide peer support specialists for the addiction treatment field. And those folks are going to work not only for us, but for other providers, community mental health centers, hospitals, health departments. One of the things that's recently happened to us is we had an executive with a major industrial maintenance company approached me. I was actually just eating in a restaurant in our town, and he said, we're needing to hire people. We can't get enough folks to pass a drug screen, and especially we need welders. So we are right now in the process of adding a welding program to what we're already doing, and that's going to allow us to create a flow not only of an opportunity to allow someone that is recovering from addiction to maybe start a job at $40,000 or $50,000 a year, but it's going to provide a flow of employees who are in some ways kind of drug proof because they've been through treatment, they've got the support. And again, that dignity of work, the confidence that comes. One of the most compelling stories I heard was one of our graduates came by my office, it was such a big deal, to tell me that he had just been to the social services office and told the worker there to take his kids off Medicaid because he had private health insurance. And that worker said it's the first time they'd ever seen that. But I could see in his eyes just tears welling up when he was able to come and share that with me and came to my office to tell me that.
That's great. And I know Sullivan University out of Louisville is partnering with you so people can also earn credentials, academic credentials with your training programs. How does that work?
Sullivan's been a great partner, and they're one of just our most outstanding private universities in the state, including having a pharmacy school. And so they just came along and said, look, we've got a responsibility as an education provider to be involved in this issue in our state. And they came to us and said, how can we be involved? And so they stepped forward and at their own cost are awarding college credit for our Peer Support Academy. Those folks are not having to pay any tuition dollars. They're awarding equivalency credit. which is fantastic. And now we've got other educational groups like our community college system who's coming to us and saying, we want to do the same thing Sullivan's doing. And again, this idea of putting vocational workforce skill building as a part of the treatment continuum, we've never seen anything increase the outcomes of our treatment programs better than this. And like I said, the first graduating class of our peer support specialist academy, we graduated 16. 14 of them today are full-time employed, they're sober, and they're 18 months at least clean and sober. And so that's 85%. That's an incredible return, and I think we can do that in all kinds of different professions.
Well, thank you. I appreciate that very much. And I don't have enough time to ask another question, but I was going to ask Ms. Minor just about working with families. But I just want to say, when you guys share your stories, that's got to be extremely difficult to do and put your family out here as you've already done earlier today, but it means a lot. I think it adds to what we're trying to do, and it certainly encourages other people, and I appreciate you doing that, all of you who've shared your personal stories and the work you do. My time has expired. I yield back.
Gentleman yields back. Ranking Member Davis, you're recognized for 5 minutes.
Thank you so much, Mr. Chairman. And for the record, I wanted to put in this State Health Reform Assistance Network article, Medicaid State's most powerful tool to combat the opioid crisis.
Without objection.
For the record, thank you very much. You know, I don't think any of us could sit here with your very compelling testimony and not be moved, not be concerned. On some levels, a little outraged as well, that we're not finding our way to provide the resources that are needed, despite, you know, with all the compelling good work that's being done in our local communities. Because I think the local communities are the foundation of how we respond, but we can't do that if we don't have the resources. And so it's very important. We're doing that in the context of contemplating trillions of dollars worth of debt that we're taking on right now, knowing that as the years go by into 2025, 2026, the families who could be hurt the most are those today that are really the most vulnerable when it comes to the use of Medicaid and help and support that's out there. So I can't help but say that because I think that we have to put this in some context. And it's wonderful to have the sympathy, the empathy, the drive to change things, but it's not going to happen if we don't recognize that we're making choices every day here in the Congress. And the choices that we're making today, unfortunately, I don't think are in line with what we see as an emergency in our country. And thank you very much for your being here because you represent really the issue that we're facing today. It was interesting to me, Mr. Robinson, as you were speaking, I couldn't help but think of some of the issues that we look at when it comes to the transition of our military into civilian workforces, and some of the issues and the need that we've had to have companies acknowledge and know more about what they're bringing to the job, all the wonderful benefits that they bring in terms of knowing how to conduct themselves at work, but also some of the trauma, in fact, that has been experienced. I wonder whether you see that there is a link, some relevance to that, and whether or not we could be looking at some of those models as well. Does that align for you?
As a grandson of a World War II veteran, this is something that's near and dear to my heart. I still remember my grandpa wearing his DAV hat, and so he taught us to take care of our military at whatever we can do. So we've had several veterans come to us for treatment because there still is a lack of access for those that are coming back. And one of the big success stories, one of the favorite stories I love to tell is Brandon Leslie, who was an Afghanistan and Iraq veteran that came to us. He was an IV needle user suffering from PTSD, went through our program, did our internship program, became a residential staff, then a center director, and now he's the assistant director over 9 residential centers. And he's only been clean and sober for 3 years. And so one of the things that I noticed was his leadership skills that were just inherent in who he is that he learned in the military. And so we need more of our veterans that are struggling active duty to get into recovery, because he can talk to them in a different way than anybody else can.
Mm-hmm. And I think that goes for Ms. Miner as well. I mean, as someone who has been clean, as you noted, for many years, you have that special gift to be able to communicate that as well. Dr. Wen, so within these discussions, I think it's clear that there needs to be a federal response with the help of our local communities. Can you say, I mean, why is that important? Why can't all this just happen if communities did the right thing?
We are already doing what we can with extremely limited resources, but I'll give you an example. Because we're out of money for Narcan, if we were to get money to purchase 10,000 units of Narcan today, I can distribute all 10,000 units by the weekend. Think about how many more thousands of lives we would be able to save every day in our local communities if we had the resources and the will to do so. The opioid epidemic is a solvable problem. This is what frustrates me every day. We know what works. We know the science is there. We just have to do the right things, including protecting existing insurance coverage, but also expanding coverage and increasing the resources to allow us to do what we already know based on evidence works.
Thank you. Thank you, Mr. Chairman.
Thank you, gentlelady. Congressman Allen, you are recognized for 5 minutes.
Thank you, Mr. Chairman, and appreciate y'all coming and sharing with us about this difficult, really difficult problem that we have in this country that really dates back to the 10th century. If you read about the problems in China, I don't know how many male citizens of the United States are on drugs, but in China in the late 1800s, over 25% of the male citizens of that country were opioid users. And of course, they went to great lengths to deal with it there. You know, when I'm out and talking with educators, and it's difficult because a lot of our educators tell me their biggest challenge, not only in elementary schools but also in colleges, is the emotional health of the student body. And you know, I look at my days in college and I thought, oh, that was a great time to be had a great time in college. It was a wonderful experience. So I don't know what's happened since I was in college. I know that I was fortunate in that drugs really did not come on the scene until I was out of college, at least at my particular college. But I saw it as soon as I got home after college with a lot of my friends who I went to high school with that became drug users. I will tell you this, we got 6.5 million jobs open in this country right now. I did a 19-county tour in August, and I met with our chambers and our county commissioners and our mayors, and economic activities at its highest level. I met with a company that's going to add 100 jobs in one county. They had 400 applicants, and only 40 could pass the drug test. Folks, we have got a serious, serious problem. I talked to law enforcement. Most of my counties, my sheriffs say that if we didn't have a drug problem, they wouldn't have anybody in prison. Now, maybe there'd be something else going on, I don't know. And a lot of it is people have entirely too much idle time. And so, you know, with that, Mr. Robinson, obviously treatment is critical, but, you know, somehow, how do we stop the supply? Because, like I said, if you read the history of China, when they cut off supply, the price went, you know, increased dramatically, which stopped a lot of the use, because right now, as I understand it, opiates are very inexpensive. The street stuff is very inexpensive to get. You got any comments on that?
I mean, I think we always have to be diligent when it comes to attacking supply. One of the problems that's happened with the prescription drug problem is that it's hard to stop the supply when you have grandmas and people who in their medicine cabinets have a 90-day prescription or a 30-day prescription for oxycodone. And the opiates we looked at 20, 25 years ago are nowhere near as potent as it is today. When you take a pill such as a OxyContin tablet that is supposed to release the morphine, the opiate over time, and then you crush it, and it gives you the full potency of that. The addictive nature of that is just so much more than maybe just the heroin that was available in the 50s and 60s. The other thing is that now we're getting these synthetic versions like carfentanil and fentanyl, which are 100 and 1,000 times, 100 and then 1,000 more times more potent.
But again, that's a business decision by the pushers to get more people addicted.
Well,
I mean, you got to go to the source here and stop this.
Yeah, absolutely.
If we get serious, we can stop it. I mean, the country, I think, has got to get serious about stopping this problem. I mean, you just can't say laissez-faire, we're going to, prescribe some byproduct. Now, obviously, we got to do something with those folks who are on drugs. But until this country decides we're going to deal with this, and we're going to deal with this in a way that we're going to stop it, I don't know how we stop it. I mean, is there any disagreement? In other words, we have a very, very serious problem here. And, I'm hearing, well, treat bud and throwing more money at it and this sort of thing. We got to stop. It's always the money. In China, you know who it was? It was the British that were making all the money off the drugs. And so, I wish you all the luck in the world, and I'm thankful for what you're doing. Thank you so much for what you're trying to do. I yield back.
Thank you. I recognize Mr. Courtney for 5 minutes.
Thank you, Mr. Chairman. I want to thank the witnesses for your thoughtful testimony today. Again, really, and the topic of the hearing, which is to sort of even get beyond the emergency, first responder healthcare, but the ripple effect that's happening in communities, which is true in New England as well. A couple of weeks ago, I was with the school superintendent up in Enfield, Connecticut, which is a suburban town in Hartford County. It's about 50,000 population, which, again, in 12 days, this year they had 13 overdoses, show up at the police and volunteer fire department. But the school superintendent actually pulled out some data which was actually it was even, another layer of alarm, because he was describing what they're seeing in kindergarten in the schools where, again, behavior is just totally unprecedented in terms of what teachers and staff are seeing. So, for example, they have the data, physical assaults in kindergarten in the school year of 2013 and 2014 were 1 for the whole district. There were 14 in 2016, last year's school year. The emergency protective holds in kindergarten in 2013 were 4. There were 114 in 2016. And again, the kids with emotional disturbance, and I'm going to submit this data for the record, Mr. Chairman. But what it's doing to teachers is that, these are veteran kindergarten teachers who are, like, at the end of the school day in tears because they're just so overwhelmed with kids. They have a term for some of the kids, they're called runners, where they just literally bolt from the classroom out the building, chasing them in the streets. And so, this has created just a challenge that, aside from everything else that school superintendents have to deal with in terms of state budgets and local property taxes, about how do you get some, stability, under the roof of a school district. So, one of the things we did in this committee with the ESSA, which was a great bipartisan achievement when signed by President Obama, but a lot of Republican members were there at the White House that updated the Elementary and Secondary Education Act. We again, really bolstered the Title II, Title I, and Title IV funding that directed money to help schools and teachers in particular to sort of get trained up to deal with these behavioral health problems, which again really didn't exist even as recent as 4 or 5 years ago. And you know, Mr. Cox, or Dr. Cox, I mean, you've really talked about this, you know, challenge that you're seeing with your staff. The Title IIA funding that came out of this year's budget from the White House and from the majority is zero. And I mean, that's the exact opposite direction we ought to be going right now in terms of what we're seeing. Because obviously, if we're talking about kids in kindergarten, I mean, this is just the bow wave. I mean, this problem is going to get worse as kids, you know, obviously come in waves in the, you know, upcoming years, as well as what their behavior is going to look like as they go through the other grades in the school system. So again, can you describe what you're seeing? I mean, are you seeing teachers who are overwhelmed with trying to deal with behavioral problems that, again, are just unprecedented?
Absolutely, and, you know, refer back to my testimony. You know, in meeting with my principals yesterday at our monthly meeting, every time I meet with them and when I visit schools, that's what I hear. And just as an example of that, I hear stories. Today we had this issue, and sometimes kids do run, but you know, the number of very serious discipline issues that the kids have just increased, and I'll benchmark it in 5 years. You know, that I've seen the sharp increase, and we have to hire additional people just to be with the kids. We don't have the funding for that. I mean, you know, we have to take it from somewhere else, and so right. You know, in our county, I mean, we have higher class sizes than we would like to, because you've got to do what you've got to do, and we don't have enough resources to do it. Well,
what you just said is exactly what Superintendent Drezick in Enfield described, which is that they need social workers, they need help, but there's, you know, they're already running into staffing challenges just in terms of, you know, having people in the classroom. And so, Mr. Chairman, again, I'd like to introduce this data from the town of Enfield for the record. And again, I want to thank the witnesses for, you know, really raising the alarm about the fact that we're just dealing with the beginning of this problem, not the end of it. Thank you.
Thank you. I'll recognize myself for 5 minutes, and I'll start with Ms. Miner, and others can weigh in. Ms. Miner, do you have any experience or have children in your programs who have experience with recovery high schools and colleges?
Not in my experience, no, I do not.
Well, I'll fire away, and maybe you have recommendations based on your work, and others can weigh in as well. The President's Commission on Opioids calls for better educating middle school, high school, and college students with the help of trained professionals such as nurses, counselors, who can assess at-risk kids. As you know, this epidemic does not just affect older working Americans, it's affecting high school and college kids as well. The President's Commission also calls for supporting collegiate recovery and changing the culture on campuses, which I think is great. There's a recovery high school in my district called McShin Academy, where they're seeing great success just 1 year into their program. And so my question is, how can we focus on supporting recovery high schools and colleges where those kids are having great success? And Ms. Miner, if you want to weigh in based on what you may have heard about them, and others if you want to weigh in as well.
Thank you. I really have not heard a lot about them. I mean, it sounds like it would be something amazing, because opioid abuse is very prevalent in high schools, in middle schools. I know my middle daughter, when she first got into abusing substances, it was prescription pills. And she was in high school. And then she had someone come up to her and say, hey, try this heroin. It's gonna get you higher, keep you high for longer, and it's more easily accessible, and it's cheaper. And then she went to that. And we need to educate our kids. It is a must. They have got to know the effects that the drugs are going to have on them, not just that day, but long term, and to be real with them. I actually go and talk in different schools, and I'm not going into the schools to tell the kids, don't do drugs because drugs are bad. I'm real with them, and I tell them, this is why you should not do the drugs, because you could wind up liking them way too much.
Thank you. Any others want to weigh in on that one? Mr. Robinson?
I think one of the reasons that works so well is because addiction is a disease, and it requires treatment and requires support. And so for kids in high school who go to a recovery high school, that gives them that support they need to have a peer support specialist, a counselor. Same thing on the college level with all the temptations that are on typical college campuses. It'd be a very hard place for somebody in addiction to go and be successful. And not just in high schools and colleges, but I think what we're doing in taking vocational workforce development to get people in addiction straight out of treatment and then give them that vocational rehabilitation and then prepare them for a job to go right to work then, to produce people who can just re-enter the workforce instead of going back and selling drugs.
Great, thank you very much. I'm going to ask a question for my colleague Jason Lewis from Minnesota, and if any of you want to weigh in on this one. Question, it's aimed at Ms. Miner again. Each of you has mentioned the importance of coordinating with other entities and services in the community. As part of the committee's work to reform the Juvenile Justice and Delinquency Prevention Act, we specifically included a renewed focus on community coordination of services to prevent and address juvenile delinquency through the Local Delinquency Prevention Grant Program. Ms. Miner, can you discuss why coordination of services at the community level, as well as identifying and addressing any gaps in services, is critical to success for at-risk youth?
I believe that it really addresses the family as a whole, not just the youth. Like we've said before, addiction is a disease and it affects the entire family. So when you're going in and you're working with these youth, more times than not, what I've seen is that the addiction goes back to the parents, back to the grandparents. So we're not just dealing with this youth who is now getting in trouble. Collaboration is a must. We've got to talk to each other so that these families do not slip through the cracks, so that we can actually better educate them on how they can help their whole family.
Okay, I'd like to recognize Ms. Blunt-Rochester for 5 minutes.
Thank you, Mr. Chairman. I first want to really thank the panel, Mr. Robinson and Ms. Miner, for your personal stories. You deeply touched me, and I want to thank you for that, and also for the work that you're doing, Dr. Wen and Dr. Cox, for being on the front lines. I'm a new member of Congress, and so to hear you reminds me again why we're here. So I want to thank you all for that. A few weeks ago, I had an opportunity to meet with neonatal nurses in the state of Delaware, and we talked about neonatal abstinence syndrome. And I wanted to go back to something in your testimony, Dr. Wen. You said that in the testimony, you said the number of babies born addicted to drugs has tripled between 1999 and 2013. Can you talk a little bit about the long-term effects of neonatal abstinence syndrome on children and their academic performance? And also, has there been enough funding or research in these areas to help us understand the effects of NAS on children as they mature? And Dr. Cox, you could also join in on that as well.
We're seeing a skyrocketing of the number of babies who are born addicted to opioids. Many of these children, many of these babies end up having severe problems from the very beginning, including seizures and other withdrawal symptoms that could be fatal. And many of them end up having long-term effects as well, including reduced academic performance. Again, emphasizing why it is that we have to intervene as early as possible. And as early as possible means that we need to provide treatment to women. We need to provide treatment to pregnant women and also to women before they get pregnant, and in general to people, because otherwise we're going to be perpetuating the cycle where poverty and trauma and violence and addiction ends up in another generation as well. And I think this illustrates the necessity of early investment, of treatment, of early detection, and also of reducing stigma. It's critical that we talk about addiction as a disease, as everyone here has been talking about, because there is treatment available, because we know that recovery is possible. And unless we fight that stigma, then people are going to continue to have a disease that otherwise would be preventable and treatable.
Great. Dr. Cox?
Sure. Dr. Wen certainly is in a better position to address the medical aspects, but again, we have about 1 in 5 of our children born in our hospital who are drug affected. And so we make an effort to reach out to them, but we are only able to service about 11% of those identified because it's voluntary. And some of the things that's reported to me, the effects, the lack of executive function that the children have, and just creating very difficult issues that gets to the learning. You have to approach that in such different ways, and that's one of the things that we struggle with.
You know, the reason why I really wanted to focus on that is particularly as ed and workforce, we're talking about not just high school and college students or those who are older, but we're talking about babies and then middle school, and as you mentioned, so it's sort of the continuum. And I want us to think about how that impacts our workforce, how that impacts the quality of life, healthcare, it's all connected. I wanted to ask also, Dr. Wen, is there a national standard of care for screening or treating NAS, and how would creating one help improve treatment for newborns?
We need to do a lot more when it comes to addressing this issue, including with a national standard. But I want to bring us back to how can we prevent neonatal abstinence syndrome to begin with, which involves early detection for pregnant women. That includes increasing our home visiting services so that we're able to bring women into treatment, and critically expanding treatment overall so that everyone has access to life-saving services.
Thank you. Thank you also for mentioning home visiting. I think that's one of the most important programs, and one that has been in jeopardy of many cuts. And so, I thank each of the panelists for your testimony, and I yield back.
I think the gentleman from Alabama is recognized for 5 minutes.
Thank you. Dr. Cox, I have a question for you. I'm a former state school board member in Alabama and sort of keep up with things. And I've heard, it's very disturbing to me, that a lot of our young athletes in high schools get injured in practice or in a game. They go to get treatment, and their physician prescribes a painkiller, an opioid for them, and they get hooked. And so I'm hearing that a large number of our young people who are hooked on opioids are actually starting out getting a legitimate prescription for pain drugs because of a sports injury, but then it just gets carried away. I mean, either they don't understand what they're on, then they get hooked and they start doing inappropriate things to get more opioids. I don't know if you've had an experience with that, if you have any views of what we can do about that.
Sure. I think it's not just student athletes, but anytime someone presents at an ER or has a pain issue, part of that, according to our Western Maryland health system, has developed ER protocols and has tried to educate ER physicians about pain management, and that certainly is a problem. We have had students, unfortunately, that have been prescribed opioids, and it's become a problem. But it's not limited to just our students, and that's an area that I think is ripe for growth too. And we have, in my opinion, too many prescriptions being written for opioids.
Yeah, I agree with you. It's bigger than athletes, but high schools, yes, the athletes are playing in our sports teams, et cetera, and so I feel like we have a little extra obligation to be looking out for them. What can we do with our student athletes?
I think it's it's an education effort, and so part of our education, Maryland has taken a lead in this. We actually have legislation that was passed this year that addresses education efforts in high schools, and we have, this is actually a copy of the Opioid Awareness and Prevention Kit, so it's a good resource from Maryland State Department of Education. It's a part of our health curriculum where we teach our children, the dangers of taking opioids when they're not absolutely necessary. So I think it's a two-part. I think it's educating physicians and folks as they present in ER, plus educating our kids through our curriculum and efforts to let them know ahead of time the dangers, that when you take substances like these, they can be addictive. So we're addressing that way.
Dr. Wen, when young people, whether student athletes or not, when they come to an emergency room or come to a physician with a problem, the young people, they don't necessarily have the same judgment as an adult does, and they don't necessarily have the same knowledge of what an adult does. What extra do we need to be doing, working with young people to help them understand, hey, this painkiller is not for you to take forever, and you need to be careful that you find yourself becoming too used to it and wanting to have it all the time, describing to them. What's the obligation of the medical profession with regard to this?
We know that there is an overprescribing of opioids that is fueling this epidemic. And the CDC has put out excellent guidelines for urging more careful prescribing, and we in Baltimore have been working with all of our doctors to ensure that those guidelines are followed. Doctors also need better tools as well. If opioids are the only tools that we have for pain management, that is what we end up turning to. But actually, there are many other alternatives that we need to be exploring. But I think you bring up a very important point about what we do for young people, because we know that what works for children is not just teaching about saying no. We also have to ensure that young people's lives are not ones that they want to escape from. And that's why the early investment in nutrition and family literacy and housing, all these other services are critical as well to prevent drug use.
Yeah, I'll just make this observation, and this is not in any way an indictment of the medical profession, but we come to you, we the non-medical profession, public, come to you when we have a health problem. We put ourselves in your hands. The parents, we put our children in your hands. Have an injured young person, you know that they're going to have a lot of pain from whatever you're doing. You're using your professional judgment as to what they should be taking to deal with that pain. Maybe there's also an obligation on behalf of the medical profession to spend a little more time with the family and the young person saying, now wait a minute, this is a very serious pain pill you're taking here. This is not something for you to take lightly. Let's go over what you should be doing and not doing with it. So I just offer that observation, not in any way as an indictment of your profession, but I think if we all work together, I think we can do something about this epidemic. With that, I yield back, Mr. Chairman.
Gentleman yields back. Ms. Adams, you're recognized for 5 minutes.
Thank you, Mr. Chairman, and thank you all very much for being here and for your testimony today. Mr. Chairman, I want to enter into the record, if we can, a Times magazine, a Times article regarding the President's desire to stop the opioid crisis and the actions that don't match.
Without objection.
Thank you very much. Let me direct this first question to Dr. Wen. Do home visiting services like Head Start and other early learning programs make an impact on the outcomes for children in difficult situations? For example, when a child suffers from trauma due to a parent's struggle?
Home visiting programs make a profound difference in children's lives and in the future of their families. Home visiting, for example, has been shown to reduce infant mortality, to improve health for children. Home visitors might, for example, find that there is paint that's peeling, that there may be lead poisoning hazards in the home. Home visiting also has been shown to increase educational outcomes for that child, as well as for the mother. There can also be detection of other issues that come up during home visiting, for example, on domestic violence, on smoking in homes, on other traumatic instances for which there are interventions that are possible. For home visiting to be effective, it must be fully funded. And not only is home visiting itself important, care coordination is important too, because we also have to identify those families that are at greatest risk in order for the home visiting to even occur in the first place.
Thank you. Are there other ways and opportunities to leverage early learning and early supports to respond to the opioid crisis?
We need to be doing everything we can to invest in our children in supports for their family, recognizing that things like housing are part of healthcare, food and nutritional support are critical to education and to health, and recognizing this life course approach is important too. If a child is experiencing trauma because of substance addiction in their families, what we have to do is to treat their families and make sure that that treatment is available at the time that people are requesting. It just is not appropriate that only 1 in 10 people who have the disease of addiction are able to get treatment. We have to invest in treatment now, because that's also key to preventing the cycle of addiction from fostering.
Thank you. Dr. Cox, the School Superintendents Association, along with the SAVE, Medicaid, and the Schools Coalition, expressed a concern about how the American Health Care Act, also known as the Trump Care Bill, would jeopardize health care for the nation's most vulnerable children. And the coalition sent a letter urging Congress to avert the harmful and unnecessary impacts that AHCA would impose on Medicaid. So can you discuss the role of Medicaid in providing the school-based health services in your county? And are you concerned about efforts to cut Medicaid there?
In my district alone, part of our funding structure is we get about $2.5 million a year in reimbursables for the medical services that are delivered to our children while at school to meet their learning needs. And a lot of that's through their IEPs. We have children that are medically fragile, all kinds of different things. AASA has taken a position on that as well. I would just reference that about 50% of my children in my district do qualify for services for the Children's Insurance Health Care, or CHIP, and so we're concerned about that as well.
Thank you very much. Ms. Miller, thank you for being here. Thank you for sharing your story. And I appreciate your comments on focusing on the whole family, which is the approach that we need to take to address this addiction. We have the jurisdiction over programs in this committee that serve pregnant mothers all the way to programs that serve the elderly. So we have that opportunity right here in our committee to address those things. Can you discuss why this holistic approach is absolutely needed?
Sure. Addiction is a family disease. It does not just affect the addict. We have got to serve the entire family. We have got to go in and we've got to educate teen moms. We've got to educate them when they're young. I have conversations with my teenagers and with my 8-year-old that are in my home all the time about drugs and alcohol and cigarettes and why they should not use them. And they carry this with them. They go into school and they talk about it. They have deep discussions with people, with their peers at school. They go out into the community and talk about it as well. It's really about prevention and intervention with the families.
Thank you very much, and Mr. Chair, I yield back my time.
Thank the gentlelady. Mr. Mitchell, you recognize? No. Ms. Stefanik, you're recognized for 5 minutes, excuse me.
Thank you, Mr. Chairman, and thank you to the committee for having this hearing today to highlight such an important issue. As we know, the opioid epidemic has wreaked havoc across this nation. I represent the North Country, which is a district in upstate New York, and we've seen an exponential increase in deaths related to the heroin and opioid crisis. And many of my local law enforcement, many of my counties, many local advocacy groups have come together to really foster these types of conversations in the local communities. My question, and I wanted to direct it to Ms. Minor to start with, I've met with so many families impacted, whether it's a recovering addict themselves, whether it's a parent who's lost an adult child, whether it's healthcare professionals, or whether it's principals and teachers. My question to you is, yes, it's important to educate our youth about risks associated with drug abuse, but I also think it's important that parents, teachers, guidance counselors, employers, managers have resources and understand what the best practices are so they can identify this early enough to help an individual seek care. Can you talk about what resources you wish you had and what best practices there are out there?
I wish that we had more beds available. When Dr. Wen had mentioned earlier about when a parent is ready and they say that they're ready to quit, it takes a lot for a parent to be able to come forth and say, I can't do this anymore, I need help. And then for them to be told, we have nothing for you, you're gonna have to wait weeks, or sometimes you have to wait months. I have seen way too many overdoses because of the parents that are waiting. They go back to what they know, and that is the substance use, to make them feel better. We absolutely have to educate everyone that is involved with this person's life, whether that be the schools, the employers, the community resource centers, anyone who comes in contact with this family. We have got to educate them and really talk about what it might look like. You know, if little Johnny's getting to school later and later, or he's missing more and more school, could there be a problem? And how the schools or whoever's coming in contact with this family can approach that child without it feeling like it's an interrogation or feeling like they've done something wrong or that they're too afraid to tell on their parents.
Let me ask you about the flip side for a parent being able to identify in their child, let's say a high school age child. I met with a recovering addict who was a nationally recognized athlete and had an injury. She went through an operation and was prescribed pain medication. That led to a downward spiral of addiction. in and out of jail. And she was a very powerful advocate about how she was very good at hiding it, she said, and her parents didn't know, her coaches, weren't aware of this issue. How do we educate the parent in that situation when the parent's not the addict, but they're the parent of a child who is the addict?
I would say we've got to break the stigma about addiction. Everybody looks at addiction as a really bad, dirty, ugly thing, and they don't look at that it could be something that's being prescribed, especially to our children, by their doctor, because we trust these doctors with our children, and they sometimes are the ones who are overprescribing our youth. And it's really about educating the parents and sitting down and talking to the parents about, differences in what their attitudes or their behaviors might be like, how they're reacting to things. I know that in my own experience that when my daughters had started in their active addiction, their behavior towards me changed. They became more aggressive towards me and wanted to argue with me about a lot more things than what they did prior to that.
And Dr. Cox, if you could follow up from a school's perspective, how do principals, teachers, coaches, guidance counselors, how do we arm them with the resources and the education they need to identify when a student is going down the path towards addiction?
Well, again, it's a part of comprehensive education effort, and that's a part of our total health curriculum that starts in elementary school where we talk about this. And we have the DARE program at 5th and 8th grade, but also it really gets intense in our high school health class where we have actually recovering addicts who speak to our students. Our sheriff comes in and talks about all the things that he has seen. So we try to give them the best information that we can so that they can at least be forewarned,
So the students are forewarned, but how about teachers, not the health teacher, but the average teacher in school? Do they have the resources and the education?
Let me give you an example of that. This, we have made it part of our professional development. This year at the beginning of school, we convened an opioid panel of community experts, and we actually recorded that. So it's been made available for our schools to use to show our teachers. That gives them the facts and information. And then
Thank you. My time's expired. I'm sorry about that.
Sure.
Thank the gentlelady. Time's expired. Mr. Day-Saulnier, you're recognized for 5 minutes.
Thank you, Madam Chairman. And I, as someone who's spent some time on this issue in the course of my public service, I just want to remind folks some startling numbers. The United States has 4% of the world population, but we consume 80% of the opioids in the world. Since 2000, over 200,000 Americans have lost their lives to opioid addiction. 4 out of 5 heroin users started with opioids. In 1995, when OxyContin started, the abuse of opioids was non-existent. Quickly thereafter, it became a catastrophe for this country. Ms. Minor, first to you, as the son of a parent who had addiction problems, who struggled with stigma and shame, I just want to tell you how proud I am of your testimony and your life testimony. And getting over stigma and shame in my relationship with my dad, who was not as successful as you, he ultimately lost his life to addiction. We've come a long way, but you telling your story. But tell me what would have happened, do you think, as you reflect back, if that child welfare worker, a public employee, hadn't interceded the way he did when he did? Where do you think your life might be right now?
I think that I would probably be dead or in prison. I really don't believe that I stood much of a chance had I not had that one person that truly believed in me and saw something in me that I was not able to see in myself at that time, and to offer the supports to me for me to remain clean.
So to take something that's very emotional and put it in a sort of actuarial perspective, and this goes to cost and responsibility and prevention. Intervention is what we should be doing, but ultimately, Dr. Wen, as a physician, we want to get to prevention and root cause. So there's a recent story, very troubling in the New Yorker, if it's true. It's titled "The Family That Built an Empire on Pain." It's about Purdue Pharma. My experience when then Attorney General Kamala Harris and I were working on simply upgrading the prescription monitoring system in California, which came to us by a software engineer who's a constituent who lost 2 children who were hit by someone who was abusing and doctor shopping. All we wanted to do was have real-time information so the Department of Justice, the pharmacist, the doctor could see if anyone was abusing. It's been in effect now, and it's worked. But it was obvious to me that the pharmaceutical industry and the lobbyists in Sacramento did not want that to happen. And I intuitively thought that it was because they were making money on the lack of our knowledge. So In this article, they talk about their senior medical advisor once publicly likening addiction of Oxycontin to celery, where he said if you take celery, he said this at an event at Columbia talking about addiction and opioids, it's healthy for you, but if you blend it and put it in your arteries, inject it, it's bad for you. So in that article, it also talks about the response from Purdue Pharma is that clients don't abuse it, drug users abuse it, which Ms. Miner strikes me as throwing it right back on the addict. And personal responsibility is also the people who sell this. So could you talk to me a little bit about addiction, prevention, root cause, and what the ultimate cause is and who pays for that?
We did not get to this problem of the opioid epidemic overnight. There are a lot of people who have to take responsibility, including me as a physician. Mm-hmm. I know that I overprescribed opioids because that is what I learned in my medical training to do. That is the culture in medicine that we have to work to change. Big Pharma, though, plays a big role in this as well. They had misleading advertising and perpetuated this pill for every pain culture. If you fall down and you bruise your knee, it's okay to have pain. You don't have to take it away. With opioids, there is a risk, there is a side effect. That's something that we can all work to change today. We've been talking a lot about education in schools, and if you ask a student, do you think heroin is good or bad? Probably they'll know that heroin is bad. But when they see their parent or their caregiver taking pills for back pain, for dental pain, that's a culture that we also have to work to change.
So you talked about, and Dr. Cox, you talked about generational addiction. So unlike tobacco, opioids, we now know, have addicted future generations. And people have benefited, just like the tobacco industry, off of this addiction. Not to ascribe blame, but trying to identify responsibility to get a prevention. So how do, Dr. Wen, back to you as a public health official, unlike tobacco, we need to go back upstream. If there was a settlement agreement some years down the road, and I know that there's litigation around the country from attorney generals, the cost seems so out of proportion to the public cost of health care around secondhand smoke.
We need much more investment, and perhaps Big Pharma can help us to pay for the effects of addiction that they have helped to create.
Maybe they should be held responsible. Thank you, Mr. Chairman.
Thank the gentleman. Gentleman from Wisconsin is recognized for 5 minutes.
A couple of questions. As has been mentioned, I don't know any child out there who could get through school without knowing that opiates are bad for you. Nevertheless, I would like, Dr. Cox said something before, and I'd like to follow up. You mentioned you had DARE and other programs in your school system. Could you or anybody else be a little more animated about what doesn't work? What are we wasting money on so we can stop wasting money on it and genuinely get people not involved in these opiates? Could you give me examples of things that don't work so you can, anybody have ideas of things that isn't working?
I think that's a hard question to answer. I mean, you're talking about messaging to kids, and that we don't really have mechanisms to know how the messages have been effective or not. You know, it's admittedly is a shotgun kind of approach.
It's shocking. You don't have any opinions on things that aren't working. I mean, I've read articles on things that aren't working. None of you up here knows things that are not working, so we can stay away from them.
Well, I will say I don't feel that anything that we're currently doing is not working. You know, we get, specifically from our DARE program, we get lots of parental feedback on that. It creates a great relationship with our law enforcement community.
You might want to Google DARE a little bit and dig a little bit deeper.
I'm aware of what you're speaking about.
Yeah. Okay. Next thing, I wonder if anybody could comment on the criminal end of this. I know in my area, at least in more liberal counties, where a lot of the drug dealing is going on, it's sometimes amazing how little the penalties are and how people are getting off with very little. Does anybody want to comment on what we could do on the criminal justice side to maybe persuade people not to become dealers? Anybody have any comments on that?
I think one of the things to get people not to be drug dealers, a lot of those, if we've got somebody that's part of a criminal syndicate, we need to prosecute them, put them in jail. But most of the dealers that we see are people that are dealing to support their habit. So the best way to get those dealers not dealing is to put them into a treatment program, give them a job skills course to allow them to go back to work and have a different way to support themselves than dealing drugs. And we have a lot of petty drug dealers that are just supporting their habit.
I'm talking about Milwaukee because I'm from Wisconsin and obviously very, liberal-ish, and maybe liberal-ish judges, liberal-ish DA. I wonder whether around the country there is also a concern that there are areas of high drug dealing in which people are not receiving appropriate sentences, given the huge number of people who are dying. Does anybody feel that you see not enough people being thrown in prison for, as a practical matter, killing people?
In Kentucky, we've broke our corrections budget. Most of our counties, the county executives, their biggest costs that they're paying out are their jail budgets. I toured a jail a couple of weeks ago that had twice as many inmates as it was set up for, because we've tried to incarcerate ourselves out of this, and we have to treat and then vocationally prepare people out of this problem.
Okay, I'll give you one more question because we're running out of time here. Are any of you aware of any studies of people who go through this? I know it can happen from any family. Horrible things can happen in any family. But on the family background of both the dealers and the people who are, arrested for possession, that sort of thing, do we have any studies on that? Any indications on where this disproportionately affects people?
We know that 8 out of 10 people who are in our jails in Maryland use illegal substances. 4 out of 10 have mental health issues.
No, okay. Mental health is a big issue, and what mental health issues are those?
It could be a combination of things: depression, schizophrenia, anxiety. They are often coexisting with substance use, and it's important for us to treat these diseases as the diseases that they are, because an investment in public health is an investment in public safety. For every $1 invested in treatment, it saves society $12, including of criminal justice and incarceration costs.
Does anybody know any different on background of these people?
When it comes to IV needle users, which are some of the folks that are most addicted, 80% of IV needle users today had a childhood trauma that is linked to their current issues. And so those early childhood traumas and not dealing with that is a major reason.
Can you describe trauma? Nobody knows what that means. What is a childhood?
I think the gentleman's time's expired.
Yeah. Could you?
Gentleman's time's expired. Gentlelady from Oregon's recognized for 5 minutes.
Thank you, Mr. Chairman. Thank you to the witnesses, especially you value all of your testimonies, but Ms. Miner, Mr. Robinson, thank you so much for being here and sharing your very personal stories. It takes courage to do that in such a public forum, but it really does make a difference. I'm from Oregon, where, of course, this is affecting every community, not just urban, but also rural communities as well. 2015, 180 people died from just prescription opioids in Oregon. That doesn't include the non-prescription. I just had a community discussion on opioids in Clatsop County, Oregon, which is a pretty rural coastal community. My constituent, Carrie Strickland, who I'd met before, she created Jordan's Hope for Recovery. She lost her son, Jordan, started with a sports injury, following up on what my colleagues already mentioned, after a 7-year struggle with addiction and relapse. And her family's loss is just a reminder that we're talking about, real people and how this affects people in communities. But there were some very common themes there about the inability, and we had this roundtable, the inability when people are ready, the inability to get them into treatment. And there are just too many barriers. Like you said, we know what to do. We just don't have the resources in many cases. This crisis is tearing our families and communities apart, but it's not the first time we went through this back. It was about 30 years ago when the crack cocaine epidemic that was disproportionately affected marginalized minority communities, and unfortunately our country tended to respond with increased criminalization of abuse and addiction. And Dr. Wen, thank you for recognizing, as others have, that addiction is a disease. We should treat it as a disease. We know that our response then affected an entire generation of people and led to some pretty severe disadvantages and stalled educational progress and poor academic, employment, and life outcomes. So this is key, the conversation that we're having today. You know, the president just declared that the opioid crisis is a public health emergency, but he didn't provide the financial resources that we need to fight the epidemic. So we don't just need a declaration, we need resources, and we know where they need to go: prevention, recovery, treatment. And by bolstering the Affordable Care Act, for example, Medicaid, fully funding the Every Student Succeeds Act, programs that provide for health services for our students who are in schools, this is all really important. I just visited a school-based health clinic in a high school in my district, and what a difference it makes for those students to have somewhere right there on campus where they can go, whether it be talk to a counselor, get a vaccination, get health care right there on campus. It really makes a difference. Dr. Cox and Dr. Wen, according to the original Adverse Childhood Experience ACE study by the CDC, individuals with 4 or more traumas were 12 times more likely to have attempted suicide, 7 times more likely to have alcoholism, and 10 times at greater risk for intravenous drug use. And we know that childhood traumas affect child brain development. Children living in households, as we heard from Ms. Minor, with addiction are living in environments of chronic toxic stress. So Warrenton Hammond, which is a school district, again in Clatsop County in my district, is helping students by their incorporating trauma-informed practices into their school system. They've shifted from a punitive to a compassionate approach to school discipline. Suspensions have gone down, attendance have improved. So Dr. Cox and Dr. Wen, you know that teachers and our school staff are oftentimes the first responders to the opioid epidemic. So are there tools and resources that teachers need to build around our knowledge of childhood trauma in order to be good first responders? And I want time for another questions.
We are starting in Baltimore City. We've started trauma-informed care trainings, including for all of our frontline city workers, such as our teachers. We've done now trainings for over 2,000 of our staff so far. It's important to shift the mentality, not look at someone as the perpetrator of violence, but rather as the victim of deep trauma, and that will help us to break the cycle that we talked about. We also have to increase mental health services and substance use services in our schools too. We have to provide services exactly where they are. In addition to recovery high schools, also increase services and screening right in our schools.
Thank you. And Dr. Cox, I want you to respond to this. During Every Student Succeeds Act reauthorization, Congress authorized Title IV-A at $1.65 billion because members on both sides of the aisle understand the importance of these programs. Title IV-A is currently funded at $400 million. Now, we've worked very closely with AASA, the School Superintendents Association, of which you are a member, to try to increase that funding. Isn't it important that Congress uphold its promise to get that funding so we can get these programs into schools?
Absolutely. It is the position of AASA that we need the complete funding.
Thank you. It's not just the flexibility, it's the funding. And finally, I just want to close with a follow-up to the DARE program. I certainly hope it's been updated from its early 80s days because it was woefully ineffective. And I'm hoping that it's to an evidence-based program because there are ways to figure out what works and what doesn't. And if it's evidence-based, that would be useful. I yield back. Thank you, Mr. Chairman.
Gentlelady's time's expired. Gentleman from Indiana is recognized for 5 minutes.
Thank you, Chairman Rokita. I want to thank the panel for your testimony today and for your stamina as we get towards the end of today's hearing. You know, in Indiana, opioids are wrecking communities and breaking hearts all across our state. President Trump was right to call this a public health emergency. And despite the hard work of our police, first responders, public health officials, and our schools, leadership all across these communities, the epidemic seems to have only gotten worse. I think we all can agree today that more needs to be done. In Indiana, drug overdose fatalities have increased by more than 500% since 1999. And estimates of the total annual cost of overdoses exceeds $1 billion just in my home state of Indiana alone. This crisis is crippling generations of Hoosiers and ripping apart their families and their communities. In Indiana, I applaud recent steps by our Governor, Eric Holcomb, who in partnership with the Hoosier healthcare providers are working to tackle this public health crisis. Their approach is designed to decrease opioid deaths, increase awareness, and decrease the number of babies born with neonatal abstinence syndrome by devoting $50 million over the next 5 years to this problem in our state. A couple quick questions. First, I wanted to start just with Dr. Cox. You gave testimony about some of the efforts in and around your school. How do you train teachers to counsel students who are coping with addiction themselves or who may have a family member dealing with the disease?
Well, it's difficult. I think part of it is developing an initial understanding of what it is, because there's so much misunderstanding about addiction. And so that's what we've tried to do. That we don't have enough time resource for professional development. That's an issue as well. So it's not just a money issue in terms of the professional development experience. But to answer your question, we need to help our teachers understand what addiction is before they can begin to help students, and then refer them to counselors.
And do you have a family-based program trying to get parents more engaged as well?
We do. Again, our sheriff has done a really remarkable job in the community, holding town hall meetings across the whole county. In fact, there's one this evening.
Yeah.
And been well attended.
Dr. Wen, I was hoping to just get any further recommendations. I mentioned in my introduction, Indiana is working on a program to tackle these challenges. And I wondered if you had any further recommendations as we get to the end of this hearing for states who are looking to implement programs to prevent deaths and increase awareness.
The first thing that we have to do is get naloxone, the antidote, into the hands of every single individual, not only first responders, but we should all be able to carry it in our medicine cabinet, in our first aid kit, in our schools, in our libraries, similar to how we have defibrillators available at all these public places. But we also have to have funding so that we can get this life-saving medication into the hands of everyone. The second is we need to have treatment for people at the time that they need. All types of treatment that are evidence-based, which includes medication-assisted treatment that's been shown to reduce illness and prevent overdose deaths. And the third is we critically have to fight stigma and encourage people to seek treatment. That also includes the prevention that we all talked about. We were speaking about schools and what we can do in our schools. The Just Say No and programs such as that are not going to be enough. The education for teachers will not be enough unless we also promote well-being overall, so that we provide children and families the support that they need in terms of food and housing and other critical services.
I do have to say to that, though, quickly, I grew up in the 1980s. I'm a child of the 1980s, and I remember the Just Say No program. Frankly, I think it mattered. I mean, the 1980s were a time when it wasn't cool to do drugs. Before that, it was cool to do drugs. After that, some said it was cool to do drugs. It wasn't cool then. And I think it is part of the answer, not the only answer, and I appreciate the rest of your testimony. In the little limited time I have left, Mr. Robinson, I'd just ask you to maybe comment a little further on the economic crisis that's being created by this opioid epidemic as well. I talk to so many employers in my home state who are saying they're having a hard time finding the workforce they need because drugs is epidemic in their community.
It's happening everywhere, and as I mentioned in my comments, our state chamber CEO says #1 economic concern in our state, and our state is moving forward with economic development. But one of the big concerns is, are we going to, as jobs come, as companies expand, are we going to be able to provide enough employees that can pass drug screens? And that's why I think one of the places that we need to look for workforce is people that are in addiction today. If we can treat them, then put them through vocational rehabilitation, and then get them a work-ready program to put them back to work. Then we can provide those employees that have been treated to those employers and meet this need.
Yeah, thanks again. Thanks for your testimony, and thank you all for being here.
Gentleman's time's expired. Mr. Barletta, gentleman from Pennsylvania, is recognized for 5 minutes.
Thank you. Mr. Robinson, you hit on exactly what I'm going to talk about right now. Whenever I sit down with Pennsylvania business owners, they tell me that a major roadblock in job growth in recent years has been directly connected to the opioid crisis. These employers have good-paying jobs that they desperately need to fill, but they can't find people who can pass a drug test for hiring. Now, Pennsylvania isn't alone in this crisis. Economist Alan Kruger identified national labor force participation for men aged 24 to 54 has fallen more in counties across America where more opioid pain medicine is prescribed. Chair of the Federal Reserve, Janet Yellen, has also acknowledged the opioid epidemic's tragic and devastating effects on the workforce. Clearly, there needs to be a plan of action to treat these folks so that they could work again. Mr. Robinson, in your testimony, you shared how the CEO of the Kentucky Chamber of Commerce identified addiction as Kentucky's #1 economic concern. What kind of partnerships has the Addiction Recovery Center formed with Kentucky workforce development boards to connect individuals who can pass a drug test with employers? And do you have any suggestions for how business owners in Pennsylvania and across the country can find qualified individuals to fill their open positions?
I think our workforce development boards need to be as involved in this opioid issue as the healthcare side of this, because treatment is essential. We can't get somebody back to work without treating them, but we also have to be able to give them an economic opportunity. And so I think the workforce boards is the logical place for us to put funding that allows them to work not only with treatment providers like us and those that are doing workforce programs, but also to work with those employers and to help us in this change in the culture, because there's a lot of employers that have zero tolerance programs. Those zero tolerance programs are not going to work in the current reality moving forward. And so we need to get those employers to start hiring some recovering addicts, because then they'll see what I've seen. A third of my workforce is recovering addicts, and they're my best employees. And so by getting those employers engaged, and we get them to the table by saying, look, if you will give second chances, we will help you with the programs, the workforce programs that you need to provide you with welders and truck drivers and some of these high-demand fields, healthcare, that they're suffering to fill those jobs.
Yeah, and I agree. And I think the first step is getting help for people, and so the public and employers and our country as a nation understand that it is a disease and an illness. These are not people who are losers and decide, they want to wreck their lives with drugs. This is an illness, and as a country, we need to understand that, get people help, treatment, and then give them another shot at life.
And we've found is we've had people come into treatment, stick around and do our workforce program. It's not 1 in 5 or 1 in 10. There's a significant number of people coming into our residential centers. If giving a career path at the time of treatment and knowing that they're going to be able to make a living on the other side of it, it increases treatment motivation, and those become some of the most successful people that we have in our communities.
Well, the worst thing we could do as a nation is help people and get them treatment, and then slam a door in their face after they've gone through that when they're looking for another chance. Thank you.
Absolutely.
Thank the gentleman. Gentleman yields back. I'd like to again thank our witnesses for taking the time to be here with our subcommittees today. I recognize Mr. Polis for closing remarks.
I want to thank our witnesses for being here today and your compelling testimony, which will also appear in the official congressional record for the benefit of members who don't serve on this committee and members who are unable to attend. Each of you shared stories and data about your work and about the individuals that are impacted by the opioid crisis. In my own community, like for so many of us, the opioid crisis has become very personal. For instance, my constituent, Carlos Santos. When Carlos was in high school, he was severely injured while playing in Summit County High School's homecoming football game. During his recovery process, he was prescribed habit-forming pain medications that later became an addiction. For years, Carlos kept finding the pills to continue his habit until his entire life and health revolved around his addiction. It took a serious drunk driving accident to finally give Carlos a wake-up call that he needed to change his life. Now, years later, Carlos has successfully battled his addiction, but we all know that many others aren't as lucky, and many pay the ultimate price. As policymakers, it's important to hear and share these stories, but we also have a responsibility to take these words and turn them into action. Throughout this hearing, we've heard about how critical funding programs are for tackling this national crisis. To truly defeat this epidemic, we need to fully fund programs that include the educational programs we've authorized in the SSA that we've talked about here today, mental health and treatment programs, research to study pain management alternatives like cannabis and others, and of course, fully fund and support Medicaid, which of course provides funding to organizations like Mr. Robinson's. I look forward to continuing to work with my Democratic and Republican colleagues towards the goal of ending the scourge of opioid and substance abuse across the country, and I yield back the balance of my time.
I thank the gentleman. Let me also add my comments and close out this hearing. Again, thank each of you for your leadership, your courage, for coming here today and helping not only these subcommittees and this committee as a whole and this Congress learn more about this crisis, this emergency, but your help to the entire nation. You are, as been said in this hearing, are on the front lines. And funding and all that surely will continue to be discussed and debated. But one thing is for sure that I learned in this hearing is that you are the solutions. We are the solutions as a community. That one-size-fits-all approach certainly won't be helpful to this, coming from Washington alone. So thank you again for your leadership. Thank you for sharing your experiences with us. As my colleague who sat in the chair here for a while, Mr. Bratt, mentioned, one of the bills we have been working to update, and apologies we didn't speak more about it in terms of how it could help, is the Juvenile Justice and Delinquency Prevention Act. Your testimony today highlights the need for reforms that encourage community collaboration and engagement, and we have done this in H.R. 1809. So this is just one example of how Congress can be supportive, as the gentleman mentions, to communities in responding to unique local needs. Again, your testimony has been invaluable as we learn more about how communities are coming together at the local level to address this epidemic, and it informs our discussions as we consider the next steps, including any legislation to help you do your jobs better, be the leaders that you are. So thank you again for everything that each of you do and all the people that you represent who are doing very similar work. Hearing no other business.
Mr. Chairman, I do have unanimous consent request. I ask unanimous consent to insert in the record a letter discussing the importance of the Medicaid expansion signed by numerous health and education organizations.
I thank the gentleman without objection, so admitted. And having no other business before the committee, we are adjourned for the day. Thank you very much.